Thank you very much. I'm really, really privileged to be here to share my knowledge about Prader Willi syndrome and also to learn from you, because much of the materials that my colleague and I have acquired over the past 25 years has really been based on parents' experience and caregivers' experience with those who have the syndrome. And we've developed hypotheses and tested them and go back to you and bring them to you, and it's an open line of communication. So we're always trying to understand the syndrome the best we can. This evening, I'm going to be talking about developmental stages, and I'm also going to be talking about behavior and a concept that we've come up with, which is the intervention pyramid in Prader Willi syndrome, to put all of the interventions sort of in a conceptual framework. So first of all, let me get an idea of how many providers we have here, how many caregivers, direct caregivers from group homes, or people who support people. Just raise your hand so I can see. Okay, it's really wonderful. Welcome. Thank you so much for coming. And parents, okay, and I didn't get to know how old your child is.
What?
Your child.
Me.
You're the child. No, you aren't. Are you a couple?
No, we don't. No,
Okay.
No, we don't. My child's,
Go ahead.
35.
Okay, all right. And yours?
Oh, I'm his sibling, a brother.
Oh, that's wonderful. That's wonderful. Because sibling relationships are the longest of our lifetime, and siblings are super important. And how old is he? 40. Okay, great. All right, so we have an interesting mix of parents and caregivers, and we have some young kids with parents here, and then we also have some middle-aged, and each has their own challenges. And that's why the first lecture really looks at developmental stages. It will become a little bit apparent as to why I did this, but part of this was done so that I have something for younger families as well as older families, and also for caregivers. So we're going to review the etiology of Prader Willi syndrome in very, very broad terms. I'm going to describe a little bit about the phenotypic symptoms as they present over the developmental period. I'll describe management tools that meet the developmental challenges associated with those symptoms, and then I'll present a conceptual framework for understanding these interventions. So I think the Prader Willi syndrome story is the most fascinating of all, because we still do not understand why the genes that are involved in this syndrome create the syndrome. So in many ways, it is still a black box. It is also fascinating because it gave us a window into understanding a particular genetic process called imprinting. And what that means is that there's a marker on this particular aspect of the chromosome, on chromosome 15, which tells us whether the genes come from the mother or come from the father. And it depends on whether they come from mom or dad as to whether they are expressed in specific parts of the brain. It's very, very fascinating, and it has grabbed my interest. And the other thing that is so important is that PWS is really a dysregulation disorder in many ways. So in all of us, the blue genes, which is the paternal genes, provide the blueprints to enable the brain to adapt to the body's environment, both inside and out. And in Prader Willi syndrome, the expression of these genes is missing. The reason for the disability is that these genes code for the various aspects of the function of the hypothalamus. So I'm going to teach you about this using your hand. So if you take your right hand and put your thumb in your palm, okay, let's pretend that this is the hypothalamus. It is in the center of your palm because it's in the center of your brain. Hi. It is the command control center of the brain. Now I'll tell you something else. It's this area that is dysfunctional in Prader Willi syndrome. These genes are coded for by paternal genes, and they are dysfunctional in PWS. Now, if you take your fingers and wrap them around your thumb, and you look at it, that's half of a brain right there. And the fingers provide the cortex of the brain, which is the thinking and problem-solving part of the brain. That, we think, is functioning much better than this part of the brain. And we'll talk about aspects of each of these as we go along. So, as I mentioned, Prader Willi syndrome is still a black box because although we know what genes are involved, we really don't know what those genes do, and we certainly don't know what they do and how they interact to then produce the symptoms associated with the disorder. So it is very much a black box. But what we know is that on the other side of the black box is an adaptability deficit disorder, because our guys, as I said, they can't adapt to the environment. And for you folks who are caregivers, that's your important role to enable them to adapt as best they can to help them be at a maximum function with support. So we know that the gene defects cause neural and endocrine dysfunction. We know that when a person has those kind of difficulties, it throws them into dysregulation so that they really can't maintain the functions, the normal functions that the body would maintain. And that causes a huge amount of stress. And because of feedback deficits, that stress is not compensated for. And this causes the person more stress and more attempts to compensate, which then feeds back and you get a number of maladaptive behaviors. And that's what makes the disorder so challenging. One of the earliest studies, and this goes back to 1987, that looked at what the nature of the eating problem was, looked at obese controls. So these were people that were fed unlimited quantities of chicken salad sandwiches. And so what you see is that people started eating, and in about 15 minutes, they plateaued. So this is the number of quarters they ate. And in about 15 minutes, most people plateaued. Some people ate a lot more than others, but nonetheless, there was a limit, and it usually reached a plateau at about 15 minutes. That's what we call satiety. That's when your body knows that enough is enough. This is what happens in PWS. So people started eating, but some of them just never stopped. Some did start to slow down, but there's still a slope to this curve, so they're still eating. But there's a tremendous variability in the amount that people would eat. And some people did plateau, and they either didn't have PWS or they certainly didn't like chicken salad sandwiches. But what's interesting is that satiety limit is missing. And so this study really was one of the earliest to suggest that the disorder in PWS is not what we typically think of as hunger, but it's actually a satiety deficit. So our feedback failure, because satiety is a feedback mechanism, and we think in Prader-Willi syndrome the feedback mechanism is faulty. So this is a global feedback failure. We see an unknown, what we don't understand, that black box, neural and endocrine deficit, that causes this global feedback failure or a lack of satiety, and that this is responsible for the eating disorder as well as other excessive behaviors that we see in the syndrome. So the point that I really want to send home is that this is not a disorder that is just about food. It's about other aspects of the person's life that they find rewarding. So the other part of it is that we actually think that people with Prader-Willi syndrome may have an increased drive for reward, and that underpins some of their reward or pleasure-seeking behaviors, which can be food-seeking and food intake, but it also can be other excessive and repetitive behaviors that they do, like their collections, or like some of the repetitive behaviors that they do to sort of straighten up or even up. We think that those might have some of these. And we also believe that because we know this is a disorder early on that is associated with failure to thrive, our guys probably have relative insensitivity to hunger, satiety. Habituation is when you do something over and over again and then you become tired of doing it. That's what most of us do. In Prader-Willi syndrome, our guys can do the same thing forever. In fact, that's one of the reasons why they are really, really great in a supported employment, because they will do tasks that many people get tired of doing, but they will do it repeatedly and to perfection. And so one of my colleagues from Norway said if you get IKEA furniture and you find that you have just the right numbers of nuts and bolts, you can be assured that a person with Prader-Willi syndrome assembled that package. Our guys also have diminished pain, and they also have diminished disgust. And so I think that that also is part of the underpinning of some of the behaviors. And also some of the skin picking, and some of the facts that our guys can really have painful situations, but they don't perceive it as painful. I had a young man who had a stress fracture, and he was walking on his leg and didn't perceive it because of the pain abnormality. And also they seem to be relatively insensitive to social disapproval. That doesn't mean that they don't seek your approval, because I think in many ways they are trying to get your praise and your approval, but they can do very outrageous things. So food is just the tip of the iceberg, and underneath is the rest of PWS. So the Prader-Willi phenotype, that is, the genes create these behavioral symptoms that we see across a number of people who have the disorder. We see it presents first in infancy with hypotonia, that's low muscle tone, and also failure to thrive. Failure to thrive means the infants do not suck, they do not eat. If they weren't supported either with tube feeding or if moms didn't work really, really hard to get them to eat, they might die. In fact, I think before we understood the syndrome, that's exactly what would have happened. We also know that Prader-Willi syndrome is an endocrine disorder. So we know now that they are, for the most part, deficient in growth hormone. They can also have other endocrine abnormalities, such as about a third will have low thyroid hormone. And we also know that there is a percentage that will also have adrenal insufficiency. The adrenal gland is the stress hormone in the body that sits right above the kidneys. And some of our guys have central adrenal problems, so that their brains do not send the signal to the adrenal gland to cause the adrenal gland to make cortisol, which is the universal stress hormone. So they definitely have endocrine difficulties. There are some other endocrine problems like oxytocin deficit, which oxytocin is the love hormone, and it's also associated with bonding, and they have deficiencies in that, and also some others. The hyperphagia and the satiety deficit, as I explained, are probably what really brought people to be focused on Prader-Willi syndrome. And the impulse control problems are really also part of the syndrome. And I think many of the parents here will say that it was when the tantrum happened for the first time that they really realized that their child was different from others, because the tantrums are legendary and over the top, and they really persist throughout adulthood. Sensory motor integration problems are present because of a phenomenon called sensory hunger, and I'll talk about that in a little bit. The excessive and repetitive behaviors sometimes are described as obsessive compulsive disorder, but I want to mention that I am a child psychiatrist, and I would characterize these as excessive and repetitive behaviors. I think that there probably are a very few of folks with PWS who do have true obsessive compulsive disorder. Hi. That's okay. But the vast majority have excessive and repetitive behaviors. That is not OCD, and you don't treat it like OCD. And across the board, our guys are stress sensitive. They are stress sensitive from the get-go. So it brought us to look at these attributes, and we wondered, are they there from the very beginning? Do they emerge at different developmental stages? Are they static over time, or do they change? Do they result from an interplay between internal and external factors? So are some of these things that people learn, or is there some way that we can modulate them by controlling the environment? And what is the role of the family in the environment in the manifestation of the symptoms? And so we looked at 4 characteristics: the food-related behaviors, the temper tantrums, the perseverative questions, and the problems with transitions, which I think everyone would agree are 4 key issues involved in the syndrome. And we did a study with a colleague, and we went to 2 parent associations. One a pretty strongly religious, very family focused, and one in a more urban area, large number of single parents. And my hypothesis was that we would see a very significant difference in these 2 groups, both in terms of stress and in terms of symptoms. And I want to tell you, across the board, everything was the same. The stress level was the same, despite the fact that the one group had very strong family supports, and in the more urban setting, all the behaviors, all the stress, it was all the same. But we learned some very interesting things. We learned that some behaviors are developmentally timed or related to developmental capacity. We knew that some behaviors were a function of learning and experience. We knew that some were opportunistic but could be changed with environmental interventions. And we knew that some were triggered or intensified by stress that could be caused from medical problems, developmental challenges, or environmental factors. And we thought that some symptoms were representative of the what we call the endophenotype. Those are the characteristics that are typical for the syndrome, and they don't change over time, and they are lifelong, and they require lifelong management. And so what did we learn? We learned that food interest increases around age 2 to 3 years, around the time of the first tantrum. Now, I think that's really important because this correlates neurodevelopmentally with the maturation of a particular part of the brain which is responsible for reward. Come join us.
We've got PW Charles.
And so we think that because these aspects of these homeostatic mechanisms are broken in PWS, it's actually the maturation of this part of the brain that is responsible for reward and learning that then enables the person to start to experience food as interesting and rewarding. And it's also the time where they start to predict what might occur next based upon what has happened in the past. And of course, we know that difficulty with expectations creates disappointment, and disappointment creates tantrums. So that's why the reward center and also that capacity to be able to make predictions about what will happen next, that's what seems to be the underpinning of the tantrums in PWS. We know that repetitive asking about events emerged as soon as kids could talk and put sentences together, and it was actually more intense than talking or arguing about food. Okay, remember, food was the tip of the iceberg, and then the bottom was everything else. We found that temper tantrums and problems with transitions increased steadily, peaked around 8 to 10 years, and they remained at high rates even through adulthood. And we also found that older individuals, like greater than 30, do display a trend toward fewer food-related behaviors. So many studies will say that there tends to be a mellowing over time. And there may be some difference in that depending upon what the genetic subtype is. So the developmental stages, and I'm going to go over the early ones quickly because we don't have anyone here who represents the smaller age, the younger age group. But I do want you to know that there is a prenatal phenotype that has been identified now. So there is no prenatal testing for Prader Willi syndrome, but what we know is by the 8th month of pregnancy that we can pretty well determine whether that child is at risk for PWS because of growth differences in the way the fetus is, and also because of the hypotonia, which is actually expressed in gestation because the babies don't move around as much. Infancy, preschool, school age, adolescent, and we'll talk about adulthood. Just going to let you look at this. The babies in utero probably don't suck either, and we think that that may be part of the reason why they end up with polyhydramnios in about a third of cases. A lot of babies present with breech presentation, which means they don't turn in the womb so that they come down head first. And there is this difference. Overall, they're small for gestational age, but there is an increased ratio of head size to abdominal girth, which we're just beginning to understand. So what we've done is we've put together this a chart that basically looks at developmental expectancies for the child, what the family should be doing at that time, and then also what should be going on in the community to optimally support the family and the child. And so this is a chart that's available on our website. It's called Developmental Stages or Transitions. And I think the key factors are the ones that I've highlighted in red. And so what I want to say is that our infants are born in crisis from the very beginning. And that level of stress persists throughout their lifespan. They really are not able to manage stress of any kind. And that's why we have to provide the extra support to them to help. It's also a huge stress for families. And I think that the first task of any family is to adjust and accept the fact that you have a child with special needs. But we also know that parents are, compared to other parents who have children with developmental disabilities, parents of children with Prader-Willi syndrome are the most stressed of all. And it's the moms who have the highest stress levels. Next are the dads. And then if you look at caregivers who manage individuals with PWS have the highest level of stress compared to any other disability. And even when you look at administrators of group homes or schools that manage individuals with PWS, their stress level is higher than working with other developmental disabilities. So across the board, PWS is hugely stressful for everyone who supports these individuals. You know, clearly the task early on is to thrive and to grow for the child, and that means for the parents that the moms really need to feed the children and make sure that they're eating adequately with the help of a dietitian early on. I want to mention that when I first started getting pictures off the internet to show folks about babies, I was seeing almost exclusively moms and babies. And people said, well, that's because the dads are taking the pictures. But now when I look, I'm so pleased to see that the dads are involved with the infants. And I think that's part of the way we're evolving, you know, as a society. But also, it's so important for dads to take a major role with their kids. They may be missing those paternal genes, but you can make up for that being present and also helping with motor stimulation for the infants. Dads have a way of exposing their kids to the world that moms don't necessarily. So if a mom has a child in a snuggly, you'll see that the baby is usually facing the mom, but if a dad is carrying their child, the baby is looking out to the world. And so I think that moms and dads really both have a very different perspective, and both are really essential in the nurturing of the child with PWS. Attaching and trusting and developing that bond and a sense of predictability and rhythms. This part of the brain is the part of the brain that does help an infant establish those rhythms. That's not going to happen in PWS. And so you have to work extra hard to try to establish that predictability. And of course, the bonding issues, we talked about the decrease in oxytocin that they have at birth compared to other infants. But it also has to do with the way the hypotonia affects the face, because they're not as emotionally they don't send emotion as well. They don't cry when they're distressed, or they don't cry in anticipation like other infants do. And that sets up a real need for increased sensory integration from early infancy. This hypotonia has a major impact on arousal level, and this stays throughout the lifespan. Even if people have growth hormone, they can still have this low level of arousal, so that you have to work really hard to get them engaged, and some of them will have difficulty with excessive daytime sleepiness. They may have difficulty with eye gaze problems, which actually persist into adulthood. They have delayed milestones across the board. I just want to mention one study that they did in Denmark. They were looking at whether heart rate varied when moms walked into the room. And what they found was that even though the baby wasn't showing any sign of distress or anticipation or wanting mom to pick her up, they noticed that the heart rate increased. And so they had us put together a grant for a study where they would put a little glow button that seemed to be related to heart rate, so that when mom would walk in the room, then the button would glow, then the mother would know to go over to pick up the baby, because otherwise there wouldn't be any other indication that the baby was anticipating mom's intervention. So those kind of things I think really help with bonding. Okay, so in the preschool years, clearly this is when we start to see an increased interest in food. Of interest, if you plot out the weights of infants with Prader Willi syndrome, preschoolers, what you'll see is their weight actually increases before there's an increase in calories. And there's a lot of debate about why this happens, but it's an interesting phenomenon. And then pretty soon you'll see that they're more interested in food. And of course, everyone is excited when they're interested in food, because that means they're out of that failure to thrive phase. But unfortunately, they have the other end of it, which is the increased interest and increased food seeking. So it's really helpful to establish in those years what is my food and what is your food. And so those are ideas, concepts that then can follow that person throughout their lifespan. And of course, around the time when the interest in food goes up, so does the tantrum. Language skills are real important. Whoops, I'm going to move to diet. There are a number of diet systems, but I think the one that has been the best studied is the red, yellow, green diet. I like the red, yellow, green diet because it does offer a lot of chewing because of green vegetables like broccoli and not necessarily green, could be cauliflower, could be green beans. There's a lot of chewing that goes on with this particular diet. And chewing is stress relieving. It also provides a lot of sensory input to the oral cavity and also to the brain. And so for a variety of reasons, this is a really helpful diet. And of course, we piloted a concept based upon what all of the families were telling us, and that is that in those families who were highly organized and highly predictable with respect to what the diet was going to be, we noticed that there was less stress in those families and there was less behavior. And the Canadians who made that lovely book called The Red, Yellow, Green Diet, they also noted that when families stuck to that diet, that there were fewer behavioral problems. And so this led us to come up with this concept of food security. So there's no doubt, no hope, of getting anything else, no chance of getting anything more than what's offered on the diet, and then there's no disappointment. When there's no disappointment, there's no behavior. Also in the preschool years is learning how to voice a complaint appropriately, to begin with social skills and play skills, and also to keep with sensory motor integration, which continues throughout the lifespan. We know now that the hypotonia, it creates a lack of sensory experience in those early years. If you think about it, all of us as parents can't wait until our child starts to take their first steps and they walk. For kids with Prader Willi syndrome, it's 10 times better for them to just stay on the ground and crawl, because they get so much more sensory input from crawling. And it does also a lot of maturation with the brain, because when you can move to a place in another part of the room and then take perspective from that place, looking backward, it really helps mature parts of the brain that have to do with point of reference. But in Prader Willi syndrome, because they're hypotonic and they have the motor difficulties, they do have relative sensory deprivation, and this actually creates sensory hunger. So it's a different kind of hunger. It's the brain's desire for sensory stimulation. And I think that that's part of what's underpinning some of those excessive and repetitive behaviors that we see. So here's the paradigm. Hypotonia causes sensory hunger, and that causes stereotypic behaviors and excessive and repetitive behaviors that result in skin picking, bowel and bathroom problems, and then also overuse of lotions, body wash, shampoo, and other toiletries. And so we like to think about everything security in PWS. So the grammar school years bring about the child's realization that they have something that's different from everybody else. I like the child that described their syndrome as food deficit disorder. I think it's interesting to ask our guys, how do you understand what you have? What do you call it? How do you describe it to other people? Food security is really essential, lifelong, but so is weight regulation. And part of weight regulation is really daily mandatory exercise. Our guys, because of the hypotonia, their energy expenditure is less than us. Treating a number of people in an inpatient facility, the only inpatient facility in the United States for management of both the behavioral as well as the obesity problems associated with PWS. Sometimes we had to get down to 600 calories to have people lose weight because their energy expenditure was so low. So mandatory exercise is absolutely essential to weight regulation. Some of our guys have difficulties with conversational skills and pragmatic language, and this really has a significant impact on their ability to sustain friends. And part of that is our guys have processing delay. Because of the nature of some of the genes that are involved in the syndrome, the neurons don't develop as fully as they do in typical brains. And so what ends up happening is that there's a processing delay. And so I think about processing is like a computer. And so if you think that there are many ways that you can get information into a computer, you can scan, you can use a disk, and then, the computer does its thing. And sometimes computers can be slow, and sometimes they can be faster, and that's really true with people too. And what happens in PWS is sometimes you can ask a question and you can actually count 1,001, 1,002, 1,003 before they respond. That's really important because typically when you ask somebody to do something and they don't respond, you assume that they're being non-compliant. So it's very, very important to understand the nature of these processing difficulties. because you can certainly get communication and behavioral difficulties that are related to frustration. Because the person also gets frustrated. Because if you ask another demand while they're still processing, they're going to miss it. But they're going to know that you're expecting something, and it's going to make it very uncomfortable for them and very frustrating for them as well. The grade school years are when children's academic performance is being evaluated, and we know that our folks do have a lot of learning disabilities. Psychological testing is really essential to help to identify those, and there are some variations, but overall our guys are usually around an IQ of about 60. But there is some variation. I've had individuals who take honors classes, but they still have to have a one-to-one aide for to manage the food-related issues. And of course, there's the other part of it where some people are more impaired. Learning to control the behavioral aspects of things is part of that need for routine, need for sameness, but most importantly, need for predictability. And so I like the train as a conceptual tool for dealing with that, because the train basically is that everything security. So the train is a tool for dealing with anxiety, insecurity, and noncompliance. And so what we do is we cue the activities of the day up on just like you would cue the cars in a train, and display that to the person visually. And so they know what's going to happen next. Otherwise, they're thinking in their mind what's going to happen next, and they're not able to pay attention to what the task is at hand. So the train is like for the day-to-day activities as food security is to food. We also know that our guys have deficiencies in executive functions. These are the things that enable us to be highly effective at what we do. Attention span, ability to initiate a task, monitoring how we're performing that task, being able to inhibit any kind of distractions that are going on or inhibit our own emotional response to things, being able to shift from one task to the next, being able to control our emotions, to be able to plan and organize materials. All of these are what we consider executive functions. And working memory. Working memory is the ability to hold multiple components of a task in mind. So if you think of long division, you have to do many different tasks in order to accomplish long division. And our guys really have difficulty holding those in mind. So we compensate for that by visually displaying things, which really helps. So executive function deficits are working memory, task shifting. Task shifting is huge. Being able to inhibit their emotional responses and emotional control, and also planning and organizing, unless it's a food heist. They're really good at that. Executive function assets, they do some things that are really good, but it sometimes gets in the way. So they need things to be just so. They have to complete a set. They need to finish before moving on. They can sustain vigilance for a very long period of time, especially if it's something that they enjoy. They are sensitive to the rules of what's expected, but they don't apply them to themselves, but they do apply to others. So I call that the PWS police. This is an example of the train. What I like about the train is that anybody can be the engineer of the train. It can be grandma, it can be dad, it can be mom, it can be teacher, it can be caregiver. And it could be caregiver per shift, so that you can block off the day into certain time periods, and then you have the activities that are supposed to occur during that time all queued up for the person. I like visually displaying it because when they know what's going to happen next, then they can use their mind for other things. And this is especially true about school. In the adolescent years, I will often have families come in and say, he's starting puberty. And people with Prader Willi syndrome really don't have a genuine puberty. I mean, sometimes they do, but it's much delayed. So there's a study now that suggests that males do seem to have a puberty in their early 20s. And some women can actually have periods on their own, but usually it's later in adulthood. Nowadays, most of the time, exogenous hormones are used. So boys are put on testosterone and girls are put on estrogen and progestins to help with maturation of secondary sexual characteristics. I'm on the fence with that. I think that there are some circumstances where I have definitely recommended it for self-esteem, but other times I see emotional and behavioral changes related to this that are not desirable. So I think each individual needs to be assessed, and there has to be a nice discussion with the physician involved and a decision made. Clearly, over time, I know that the sex steroids are used as a way of helping combat osteoporosis, which is a fairly significant problem in our population. But that can also be addressed through the use of weight bearing and exercise. And I think we get a little too complacent sometimes about taking a pill. And so we should look at other ways. I think that the adolescent years are a time where our folks need to understand modesty and understand that they have a special body that is different from others, and that they also need help. So it is an adaptability deficit disorder, the other ADD that psychiatrists treat. And that's where all of us come in handy, because we help the individuals achieve maximum function with support. So I want to describe how stress impacts our guys. Each individual can have their own little personality profile that is across a variety of domains, which can be related to food, non-food reward items, disruptive behavior, cognitive rigidity, and stress and anxiety and mood problems. So each person has their own little PWS personality, and that's typical for them. But what happens under stress is that there's an increased intensity of those typical behaviors. So if the baseline behavior is arguing about things, then maybe the increased intensity of typical behaviors might be being disruptive, taking that to another level. And then there comes a point at which that stress just builds up, and then it just tips over the edge. And then aberrant behaviors happen, and that means that those are behaviors by anybody's definition are abnormal and can be to the point of being outrageous. So what we know in PWS, they're stressed to begin with, but as stress goes up, their coping abilities diminish. And so this is what happens in adolescence, because there are many, many more expectations and also degrees of freedom that are afforded people at this age. And it puts our guys in a situation where people are expecting more of them. And they might have to make multiple transitions through the day. And with all of those comes increased stress and increased difficulties. It also can create some existential issues for them, which is, they're coming to realize that they have a disorder that may not allow them to have children or to get married or to have the kind of job that they want. So they have to start to begin to have more realistic expectations. And I want to mention the issue about healthy education. I think that the best way, because I've told you about our guys liking things that are rewarding, they can find cigarettes to be very rewarding, not because of the effect of the nicotine, because we don't believe they have the same response to nicotine that we do. because there is this feedback deficit. So our guys, when they smoke, they can just basically suck down one cigarette after the next, after the next, after the next. And it can become a really, really huge problem and can be a real health concern. And so my way of looking at this is, try to keep them abstinent, talk about the risks of smoking. But I think, unfortunately, one of the major reasons why they start smoking is because they see others doing it. And so when you move into, adolescence or into young adulthood, when you're going to work programs or when you're with staff and staff might smoke and people see those individuals, then they start to want to do that themselves. And it really becomes a problem to stop. I also am a strong advocate about legal guardianship. And I think that should occur sometime between 18 and 21 years. And the reason is because our guys, regardless of IQ, really lack the capacity to understand how their how their syndrome interferes with their ability to make decisions. And I'll give you an example. We had a young man who very, very stress sensitive, also very, very food obsessed. And he had a habit of ingesting things when he became very, very anxious. So he unfortunately got a Lego piece and put it in his mouth and swallowed it, and it got stuck in his esophagus. And so we took him to the emergency room, and the emergency room physician explained that it was stuck there and it had to be retrieved mechanically. And the way that this had to occur, it had to go under anesthesia, and it meant that the person had to be nothing by mouth for the entire rest of the day, and then they would do this first thing in the morning. And the patient looked at the doctor and said, "Absolutely not. I'm gonna have my dinner." And the doctor just couldn't reason with him. And of course, the doctor couldn't reason with him because he was not able to understand the seriousness of his problem, and nor could he separate his desire for food from the need for his physical well-being. We did get guardianship, but actually we didn't need it because we just told him that we understood that he wanted his dinner, and so that we would save his dinner so that after he had the procedure first thing in the morning, that he could have his dinner and then he could have his breakfast and he was perfectly fine with that. So as long as that's that food security, as long as he knew he was going to have it, he was perfectly okay with that. But that gives you an example. When push comes to shove, our guys really can't make the best possible decision. The other thing is our guys are not good at financial things. And one of the things I meant to mention about the learning disabilities is pretty much across the board, our guys are not good at math. And I think it's part of that working memory deficit, but they really don't get quantities. In fact, more is always better. There's just, they don't know relative amounts. So for all of those reasons, we really do recommend legal guardianship. I always have to render decisions as a psychiatrist about individuals who get themselves in trouble with the law. And it is really complicated because the legal system defines competency very different from the way psychiatrists do. But nonetheless, I think legal guardianship is really essential. In the young adult years, this is the time when, we like to think that our folks with Prader Willi syndrome are going to be leaving home and going to group homes. So we had a wise mom who said, to her eldest, who happened to be a son, "You are going into the Army." And she said to her daughter, "You are going to go to college." And she looked at her child with Prader Willi syndrome, and "You are going to go to a group home." And I realized today that's not always a possibility because there are different ways of looking at how to support individuals in the community once they become adults. A group home affords a Prader Willi group home affords some special advantages because you get to cluster people together so that the environment is the same for all of them. The advantage of that is that they see that other people have the same roles, and other people have the same food restrictions, and other people have the same needs for structure and mandatory exercise. And you can often use that to their advantage because they can be competitive, and so it really helps having a bunch of folks with PWS together. It also presents some special challenges. But I like the idea of having people live together. I think it makes it easier for them. So environmental management for our guys really is always this balance between the restrictive nature of what we have to do to keep them safe versus what they want to do to really to realize their own personal dreams and ambitions in life. But the environment really is the tool to help manage their well-being. I think group homes and residential treatment facilities provide a secure environment and that they can expect to lead productive lives at healthy weight. And that's really the key. And one of my German colleagues said that with food security, the brain can think of other things. These are all guys at a residential treatment facility in the U.S. So again, the mantra for the young adult, or any adult, is maximum function with support. Many of our guys find work to be very rewarding. There are kinds of work that they are really good at doing. I think many of them are good at doing laundry. Many of them are good at doing assembly tasks. Some are good at pets and caregiving. Others not so much, depending on that person's history. But I think that having a job and a source of self-esteem is really important to our guys. And then I also want to mention that I haven't spent a lot of time talking about genetic subtypes, but depending upon the person's genetic subtype, there is more risk for mood disorders and also some psychosis. And what we seem to understand now is that individuals with the uniparental disomy condition, that would be 2 of mommy's chromosomes, tend to be at greater risk for something that looks like bipolar disorder, whereas individuals with the deletion condition seem to be at greater risk for anxiety and depression with age. Across the board, our guys are stressed. And that stress really has to be managed. And it doesn't take much to push them over into their stress mode. I think that each individual has their own kind of coping strategies. I frequently will do an anatomy of a tantrum where you look at that person and how they start to begin to escalate. And at some points along those early times, you might be able to distract them and sort of eliminate that risk of blow up, but then inevitably the tantrum will happen. And then I look at the tantrum as sort of a physiological reset, because oftentimes after it's done, it's done. We're holding the grudge because of what happened, but they're completely done. And they really can't understand why we're upset because for them it's over and done, and it's in the past and let's move on. The beauty of the train is that they can be outrageous, but if they can get themselves reorganized and get themselves back on the train, they're back on their way to success. Sensory stimulation is essential because of sensory hunger. And I think what typically happens as people age is that they sort of age out of those things that provide a lot of sensory stimulation. I've joked about this, but I think that, part of the birthright for all of our guys should be a lifetime pass to amusement parks. because our guys don't have that kind of butterflies in the stomach experience, so they can tolerate roller coasters and things that spin you around, and it's an infinite source of sensory motor integration for them that they desperately need. I think things like equestrian therapy is really good. I have some of these activities that I think are really helpful for decreasing the skin picking. And by the way, chewing gum, just to put in a note for that, we talked about with the diet how chewing is really stress relieving. Chewing also helps promote gastric emptying. Some of our individuals have tendency to have gastroparesis, which can be a really strong medical risk factor. But at this facility that I consult to, one person was having rumination, so she would eat and then she would bring her food back up, and I suggested that she chew gum, which worked beautifully, but unfortunately everybody wanted to chew gum. And so what they did was, after dinner, after a meal, they gave everybody gum. But the unexpected thing that they found, the rates of skin picking went way down. So it doesn't have to be specific to the topographical site, but just increasing the amount of sensory stimulation can really work very effectively. If you have individuals who do a lot of picking, you can use bubble pack. We have individuals who love string, or something they call, in the U.S. we call it GIMP, which is something that you can work with and tie knots in, and they really like that. Vibration is not impaired, so we've had some individuals with some rectal picking where we've actually used vibration to the heels of the feet. And thinking about the dermatomes, it really sort of goes to the right place to compete with the stimulation that the person might get from picking. And that has worked effectively. And then, of course, deep pressure like massage. I have a young lady who has meltdowns every time she makes the transition from her van from work to her group home. And all they need to do is deep pressure on her shoulders, and she just simply melts. And so I can't keep affirming the need for sensory stimulation in our guys. We had one guy, just a back massage. There are so many nerves that go to the back. Just a back massage was so effective in decreasing behavior for him. Adult friendships are real important for our guys. Long-term romantic relationships don't necessarily have to involve sex. We've had some incredibly lovely long-distance relationships where individuals see each other once a year at the PWSA meetings. In this day and age of social media, that provides another opportunity for people to make contact. Social media is also a problem because our guys can enjoy computer time and get to other sites that are probably not so healthy. I want to mention sibling relationships again, because those relationships are the longest that you will have in your lifetime. And I think after parents are gone, it's the siblings who assume the roles of guardians. I think that parents tend to protect siblings from the kids with PWS, and I think that at some point that sort of separates them from knowing about the person and also knowing about the syndrome. So I think making that information available to them is important. And now I know a lot of the associations also offer programs for siblings, which I think is really terrific. And then finally, I think our guys have this capacity for belief, and I think religious belief is very important, or can be very important to them. It can be a source of social relationships. It can help them with volunteering. It could also be a source of food, but in one of the larger group home systems in Germany, which is religious, our guys routinely serve as acolytes for the service, and do not take advantage of communion. They only go once. And we've also had individuals who fast for the religious holidays. And so it's all about what they find to be rewarding. And if their religious affiliation is important to them, they can be extraordinary. So I think this helps you see how PWS sort of fits both within the family and then also within the community, and how we can support them optimally. Thanks. Any questions? Yeah, so the question is about a 14-year-old who is developmentally delayed and also emotionally delayed as well. Right. Yes. Okay. So that's a very what was just said is, for those that didn't hear, is that this is an individual who, in many ways, sort of behaviorally and emotionally, is much more like a child of about 5. And you can't reason with him in order to get him to behave developmentally appropriately, which would be up to a level of what you would expect for a 14-year-old. And I think that this is not unusual for PWS. And I think that if you think about this in terms of cognitive abilities, and think of it in terms of social function, and look at it in an emotional function, what we're looking at is that individuals with PWS are significantly delayed in their emotional maturity. So in many ways, they are more like kids of between 4 and 6, except for the fact that they can be 35. And at some points, they can appear to be, an adult. But when they experience disappointment or stress, immediately it's like that regressive behavior emerges. And that is part of the phenotype. That is characteristic for the syndrome. And I think that the challenge for our guys is that they are not at a developmental level compared to their peers.
Oh, very much.
For the most part. And so it's really hard to find peers that will match them. And the other comment that I want to make is that I see this in the grade school years, actually, that during preschool, you can see that our guys can sort of keep up with the other folks because the demand for language is significantly less. But once the demand for language is present, our guys are really at a disadvantage because of those processing difficulties. So by the time our guys are trying to come up with a response to what someone has said, that person has listener fatigue, and you see them, they turn away and they talk to somebody else. When our guys are successful, they're successful in a one-to-one interaction. Once you enter into a group, it's really complicated for them.